Our guest today, Dr. Peter Zandi, is the Arlene and Robert Kogut Professor of Mood Disorders and Vice Chair of Precision Medicine in the Department of Psychiatry and Behavioral Sciences at the Johns Hopkins School of Medicine. He's co-director of the Johns Hopkins Precision Medicine Center of Excellence on Mood Disorders and Research, and a champion for the National Network of Depression Centers. We'll discuss his seminal work on building a learning health system founded on measurement-based care at the Johns Hopkins Department of Psychiatry and Behavioral Health, as well as building a groundbreaking learning health network for mood disorders across 16 different U.S. healthcare organizations. I'm here with Dr. Peter Zandi. Welcome, Peter.
Thank you for having me.
So before we actually get started into the meat of the matter, in which we are actually going to talk a lot about measurement-based care and your program that kind of puts measurement-based care on steroids, why don't you tell our listeners a little bit about what you'd like them to know about yourself instead of me giving the long academic introduction?
Yeah, so I guess one question becomes, why did I become interested in this field? And so there's a bit of a personal story there. My mom has struggled with bipolar disorder, schizoaffective disorder for much of her life. Growing up, we've had to deal with that and her illness. And that's what got me interested in thinking about mental health from a personal perspective. And I always knew I wanted to do medical research. I just wasn't quite sure in what direction. I ended up doing work in epidemiology, and that led me to thinking about how to use epidemiology to understand mental illness, the causes, consequences, and how we could treat it better. And so much of my work in academia over the past 20, 25 years has, it's probably longer than 25. It's about 25 years now, but we'll not go into more depth about that. But much of my work has been motivated by those personal experiences and how can we understand mental illness better and provide a way of intervening in folks who are struggling with it and folks who are dealing with loved ones who are struggling with those illnesses. So maybe that gives you a little bit of understanding of my motivation for the kind of work that I'm doing.
Well, thanks so much for sharing that. It is always remarkable, isn't it, what personal journeys place us on in terms of our occupational journeys and things like that. They can be very compelling. So that is very helpful. One of the things that I think when I've just looked a bit at your CV and things like that, one of the things I'm curious about is, as you've already mentioned, you've spent a good portion of your career looking at the genetics, the etiology of bipolar disorder, other mood disturbances. You were an epidemiologist by training. How did you actually make the transition, although certainly you haven't left your previous research, but how did you make the transition to be interested in what I would think of as healthcare systems operations? And that actually might get us for me to ask you about measurement-based care, which was the main reason that we've got you here, because you've really created something quite amazing, you and others, I understand.
Yeah, no, it's an interesting question because I'll admit it. Yeah, I did not think I would be doing health services, operations type work or related research, but a lot of my work thinks a lot about the health system and the delivery of mental health care and how can we provide better delivery of care and how can we leverage that into this idea of a learning health network or system idea, which I'm sure we'll talk about later. So you're right. It comes as a surprise to me, actually, as well, that I am this much involved in that kind of work. It started out, my early work was very interested in the etiology side. By etiology, I mean the causes of illness. And it was much of my early work was motivated by thinking a lot about how genetic factors contribute to risk for illness. Again, that might harken back to what I was just talking about, motivation. My mom was struggling with illness. I wanted to understand what was the genetic contribution. And there's lots of evidence and data out there, as we all know, that suggests that genetic factors are an important contributor. Certainly not the only risk factor. And we know there's complex interplay between genetic and environmental factors, but genetics do clearly play some role. And so much of my early work when I was as a doctoral student and an early faculty was thinking about how to delve into that and understand the genetic contribution to these illnesses, these complex psychiatric disorders, whether they're mood disorders, depression or bipolar disorder, or other severe mental illnesses like schizophrenia or anxiety disorders. So in my early career, I was involved in these genetic studies that had been evolving over the late 1900s, 1990s, and the early 2000s. And it was remarkable how much the field has been evolving in genetic research. Just technology is changing, and it opened up a lot of powerful tools for understanding the genetic contribution to these illnesses. And I was involved in a lot of these early studies, doing what are called genome-wide association studies. This was a new paradigm for studying the genetic contribution to common disorders. And they were motivated by this idea that you needed large sample sizes to have sufficient power to identify these genetic variants that we think contribute to risk for complex disorders. And doing these studies was very challenging because, like I said, you needed very large sample sizes. And at the same time, you wanted to have a lot of good clinical information on these individuals that you're recruiting into these studies so you could do more sophisticated analyses to see how these genetic variants might contribute to risk for these disorders by having a more nuanced and better understanding of people's clinical experiences, their experience with the mental illness, the phenotype side of things.
Right.
So there was this very clear tension between trying to get large sample sizes of individuals with these severe mental illnesses to have sufficient power, but also having good clinical data on them. And so this led me to thinking about, well, what can we do? How can we overcome this fundamental problem? And it was around this time, this idea of a learning health system was gaining currency in the field. This idea of we're out there providing care to all these individuals, and the clinical care was very divorced from the research that we were doing.
Right.
And so I was thinking a lot about how do we integrate those so they're not siloed. That there's these folks who are providing clinical care to all these individuals who are struggling with depression and bipolar disorder. And then we're over here doing research, trying to recruit people and trying to phenotype them. Can't we bring that together? And that learning health system was sort of this nexus of idea of integrating clinical care and research. That is, as we're providing care in all these different health systems to folks with these illnesses, can we gather information in a way that helps us integrate the two enterprises, clinical care and research, so that we get large samples of individuals, but at the same time have better data on them, more information to help us understand what's going on. And so that led me to this idea of trying to build a learning health network or systems for mood disorders where we could have following lots of individuals, getting as much information about what's going on in their lives, including genetic information, to make headway in trying to understand how all these factors come together. And in doing that, the more and more as I was doing this, the more I had realized I had to understand the health network, the health systems. Where are individuals with depression and bipolar disorder getting care? Where are they being seen? How can we make that clinical enterprise more efficient in a way that's useful for the clinical enterprise, but at the same time gets us information that's useful for the research enterprise?
So that's the kind of thing that started driving you to be looking
Exactly.
another way.
Yeah.
It's sort of interesting that you say that, because I certainly remember when the learning health system paradigm, hit the
Yeah.
scientific news, if you will, and the
Right.
clinical news. And there was a lot of interest in it. And in fact, at the Children's Hospital of Eastern Ontario Research Institute, where I am, we actually held a whole weeks-long sort of set of talks and visiting speakers on building a learning health system. But generally, what happened was that the learning health system paradigm didn't really get legs. I mean, it was really nice, but very few places could actually put it into action.
Right.
And do you have any ideas about why it actually didn't get put into action very well? Maybe some of the things you might have addressed in the recent years?
Yeah. Well, so first of all, the learning health system idea is a pretty broad concept, and people have different ideas about what constitutes a learning health system and what's the best way to implement this idea of a learning health system. So I think there was a lot in the early days of thinking about, okay, what do we mean by a learning health system for psychiatric illnesses like mood disorders, and how do we even get one started? And for us, what we started to think about is this is a big issue. We got to just take it one step at a time, try to bootstrap this idea of building a learning health system, of bringing together a clinical care enterprise with a research enterprise in a way that really achieves this idea of a learning health system. And that's when we really hit on this idea of measurement-based care, which is another sort of concept that we've talked a lot. You and I have been talking about.
Yes.
Became sort of central to this idea. Okay, let's use this idea of measurement-based care as an engine for starting to bring together the crucial elements that will make up a successful learning health system.
Yeah, and I love that analogy to an engine. Perhaps for our listeners, it'd be good if you could define what you mean by a measurement-based care system.
Yeah. So the basic idea of measurement-based care, and it's really not rocket science, but it's this notion that we should be doing a better job of objectively tracking and monitoring how our patients are doing, the people that we're caring for are doing with care, and how they're coping with their particular struggles and their illnesses. So can we utilize objective measures, whether they're patient-rated measures or clinician-rated measures, or maybe other measures as well, that help us understand how the individual is doing, and to use those measures not merely as a screening tool. That's a big point, because in the early days of thinking about measurement-based care and using these measures, people thought in terms of screening. Let's do a screen. But that's not sufficient. That's just kind of a one-off. Let's see how patients are doing and then triage them into different types of care. Can we use these measures to follow individuals prospectively over time as they're receiving care? And then to use those measures as part of the clinical encounter, both for the clinician and the individual person who the clinician is treating, to look at how they're doing and collaboratively make treatment decisions and make treatment adjustments in a more timely manner if needed. And so that's basically the idea of measurement-based care. Again, that doesn't sound like rocket science, but for those of us who are thinking about implementing measurement-based care, and for me, this is around 2016, 2017, it wasn't what was commonly done.
Right, it just wasn't happening, right?
Clinicians felt like they had the best relationship with their patients, and that's true, they had a good relationship, but they also felt that they didn't need these measures. And so there was a bit of a culture against this idea of doing these objective measures, and for a variety of reasons. Now, that has shifted over the past 5 to 10 years, where I think most people see the value of objectively following how these patients are doing that we're caring for over time and using that information.
Did the electronic health record coming into use in a widespread way have anything to do with us being able to build measurement-based care or even think about it?
Well, it absolutely had an impact on the uptake of measurement-based care. prior to the adoption, the widespread adoption of electronic health records, when people thought about measurement-based care, the notion is an individual would come into the clinic, they would be given a clipboard, and they would complete some of these measures on paper.
Yep.
And then oftentimes, I myself would have this experience, you would give that to the front desk, they would take it, they would file it away, and you would never see it again. So who knows what that information, whether it was being used or how it was being used. And so it was just a very inefficient system. That changed with the electronic health records. So when are we talking? Just to give you an example, at Johns Hopkins, we adopted, there was some legacy electronic health record systems, but it was very scattered across the different healthcare systems. But in 2013, they made the decision to get into a contract with Epic to adopt the Epic EHR as enterprise-wide. So between 2013 to 2016, it took that long to disseminate and implement the EHR system across the entire Hopkins health system. And this was a common experience of many of the academic centers. So this is the time we're talking about. And that all of a sudden gave a platform that clinicians, although they sometimes did not like interacting with the electronic health record because it introduced sort of a barrier between them and interacting with the patients. Again, that's changed over time as electronic health records have become more user-friendly. But this became the primary means by which information was captured during the clinical encounter. So that's crucial.
So in precision child and youth mental health or precision mental health generally, it doesn't matter if it's children or youth or adults, we often say that the learning health system was one of the foundational pillars, even though it, may not have gotten built robustly.
Right.
And so what I hear you saying is that you began to see that measurement-based care was crucial to support a learning health system, which would not only combine research and clinical care, but also provide output to the patients themselves.
Yep, exactly. Yeah.
And so what you then decided was you were able to start looking at how to build measurement-based care into the electronic health record in the Johns Hopkins system.
Exactly.
So tell me how that went.
Yeah. So it takes some time and some energy. It doesn't happen overnight. There are, a couple of challenges. The one is the cultural barrier that we talked about first. We started working with our clinics where we're providing care to individuals with depression and bipolar disorder. And as I mentioned, when we first went into these clinics, we said, hey, look, we want to develop this system where we're going to capture these standardized outcome measures and have it be useful to you and the patients, as well as to feed this learning health system. There was reluctance at first. This is going to be additional work that we're going to have to worry about. This is going to slow the clinical workflow of patients coming through our clinic. All kinds of questions and challenges. And so there's the cultural challenges. Then there's the technological challenges. You have to work to deploy these measures to figure out how to leverage the electronic health record system to allow you to assign and deploy these measures in a way that's efficient. And so there's the cultural and there's the technological challenges, and you try to work with both. And it took us several years to working both with our clinics to get them to accept this idea that this is a good thing to do for them as well as for the broader goal of learning from our patients. And it also took us a while to work with the Johns Hopkins health system, to work with Epic, to deploy these measures within the electronic health record. And as we're doing this, we're constantly thinking about how to make this system more efficient for everybody. How do we, the term we would use is, how do we reduce the friction? Well, the first one was, okay, let's stop capturing it on paper forms.
Okay.
That's a friction point because it goes into a clipboard, goes in the desk, nobody uses it. And we really wanted these measurements that we were capturing to be utilized clinically because there's lots of evidence to suggest it's good practice. So that meant, okay, we're going to have to deploy it where the clinicians are. That's in the electronic health record system. So we wanted to make sure that we leverage the EHR so that these measures could be captured in a way that didn't add burden to the clinicians and didn't require them to log out of the EHR, go to another informatics system on the web, put in another password and log in. 1 or 2 clicks might sound like a little, but that's like the Grand Canyon when you're trying to get over that hurdle for getting clinicians to change their behavior. So we're constantly, as we're going through this process, thinking, how do we reduce that friction to both improve the culture of adopting this and the technology to make it useful? And another part of this, which is we're still working on, to be honest, is well, we're working on all parts of that, but the other part is how to make it useful to the patients themselves. You brought this up. We're capturing this information. We want the clinicians to use it, but we also want to empower the individual so that they can have look at their own data and use that data and that information in consultation, in collaboration with their clinicians to make treatment decisions. And so we're thinking about how do we get that information and deliver that back to the individuals so that they have that information as well. And we're still working on that, how to best do that.
It sounds like you've got a work in progress, but you've made great advances in the Johns Hopkins system, which I want to clarify is multiple sites.
Yes.
So it's not just one hospital. But you've really done a lot of great work and you've learned a lot of good lessons. And you've published some data out of that, for sure. So we know now that we've got the MBC is built and you've done a really good job across these systems. Then somehow you came up with the idea that the learning health system could be more beneficial if it was a learning health network. And could you tell us just a few sentences about that?
Sure. And this is I should emphasize collaborative work with many folks who are thinking along the same lines that learning health, the power of the network has a lot of advantages and benefits to think about. And so what you're referring to is our work as part of the National Network of Depression Centers, the NNDC, as we affectionately refer to it. Is this collaboration, a consortium of over 25 and growing centers across the country of folks who are providing specialty care in mood disorders, depression and bipolar disorder. And some really folks with a lot of foresight, folks who are my mentors, thought of putting this network together to bring the network to think about how can we leverage the power of the network for what we're doing. I mean, the motivation for the NNDC is a little bit of a side story. Is the cancer centers in the U.S. where they were able to form a network of these cancer centers that really helped us advance the treatment and care of folks with cancer through these cancer networks and these trial networks. So that was an early motivation. And one of the first initiatives, flagship initiatives of the NNDC was to create this mood outcomes program, which was a measurement-based care program that where we were going to implement the same ideas that we were doing at Hopkins across all these centers. Now, the way I just described it, I should clarify, this is all happening in parallel. We're learning to do this at the same time. As we were implementing measurement-based care in Hopkins, we're thinking about it in the network. So it wasn't like we did it at Hopkins and let's disseminate it across the network. I just want to be, this was sort of a collaborative, iterative process where we were coming around to this idea of measurement-based care is a really important thing to do, as we just talked about. Let's implement that as part of standard of care, not only at Hopkins, but all these centers. And then let's use that as an engine now for not only a learning health system at one academic medical center, but as an engine for the entire learning health network of these academic medical centers across the country.
So that's where kind of it's MBC on steroids, as I mentioned in the beginning. So that's been going on for a few years.
Yeah. So, like I said, our work at Hopkins has really been going on in parallel with the work in the NNDC. and with the mood outcomes program. That mood outcomes program has gone through many iterations as we've learned about how to apply measurement-based care. And the work really started around 2015, 2016. So around the same time we were starting to think about it at Hopkins. And like I said, it's gone through several iterations. Now, and I could bore you with the details. There's actually a very interesting story about that evolution. Well, maybe it's interesting to me. It might be boring to other folks. But I could go into those details maybe at another time. Or
maybe at another time would be
exactly.
good. Because I'm very interested to hear some of the results that you're getting out of the network.
The idea, though, was that we learned how to be more efficient about delivering this idea, again, of friction. How do we reduce the friction to increase the uptake and the adoption of measurement-based care? Now, not only at Hopkins, but all these medical centers across the country. And so we've been working on that over the past 10 years, and it has picked up a lot of momentum. We've, as mentioned before, have followed over 130,000 patients through the Mood Outcomes program across these centers. I should mention, and I think I have in our other conversations, we are at this transition point with the Mood Outcomes program. We are really trying to expand what we're doing. You mentioned it on steroids. It's measurement-based care maybe on our first generation of steroids. We are trying to use it now into our next generation or second generation of steroids, whatever that might be, where we're trying to expand the implementation of the program across more of our centers and more of our clinics within those centers. I think that's an important point you alluded to. It's not just, for example, at Hopkins, it's not just one center. There's many centers and many clinics within many of these academic medical centers where we see individuals with depression, bipolar disorder. And so we want to be implementing this program at all those clinics.
So there's kind of a force multiplication process.
Exactly.
You've got a center, but it actually comprises multiple. So it sounds like you've got loads of patients so far. What are some of the things you've found out so far? Things like maybe about different treatments or things like that?
Yeah, so that's where we're in the early stages, to be honest, of learning. A lot of the work over the past 10 years is building the infrastructure, the plumbing, if you will, of bringing this information together. And it's only now that we're in a position, especially as we talk about this transition that I mentioned, to start to make greater insights into what this data is telling us. One thing that I was mentioning about this expansion is, in addition to expanding to more clinics, we are expanding the types of data that we are capturing from those health systems, so that we're getting more information from the electronic health record from each of those academic medical centers to grow into the central repository, so we'll have an even greater power to address some of these questions. So I bring that up because we're still learning, actually, and I feel like we're actually just at the beginning of that journey. And so what we're doing right now is starting to put that data together of the outcome measures that we've captured longitudinally on these individuals over time, both at Johns Hopkins. As I mentioned, we now have data on over around 40,000 patients at Johns Hopkins. And we have similar data on around 100,000 patients from across the NNDC. And this is all longitudinal information on these outcome measures. And so we're starting to put together, to dive into that data to understand, to be able to describe the trajectories on those outcome measures, right? We have outcome measures that track mood symptoms, depressive symptoms through this measure called the PHQ-9, or anxiety symptoms, or suicidal ideation and behavior. And what we'd like to know is how does people's responses to those trajectories track over time? It's kind of interesting, actually, in our early look at the data. It's really quite highly correlated. That is, individuals who tend to score high, they tend to score high throughout, unfortunately. And people who tend to score low tend to score low. So at first blush, the thought is, oh, well, that's a little maybe disheartening that there isn't any change on those measures. But what we're starting to think about is that maybe change relative to one's own individual sort of innate baseline might be most relevant for understanding what is working and what isn't working. So we're thinking a lot about how to look at that data to borrow information across the entire sample. That's what we kind of do now, right? We have these thresholds on these measures, the PHQ-9,
Right.
where we say if somebody scores higher than 10 or higher, they have moderate depression. If they score between a 5 and 10, they have a mild depression. Those are metrics, thresholds that are based on defining across the entire population. What that doesn't take into account is one's own individual history.
Right.
So we are trying to now think of ways of making inferences about how a patient is doing, not by borrowing information across the population as well as their own personal information. And that might be better for us to personalize care to them, to understand their trajectory of illness.
Kind of person-centered analysis.
Person-centered, exactly. Right. So we're really interested in that idea, and we now have the data to try to see how can we combine that population information with that personal trajectory information.
So perfectly aligned with what we're trying to do generally with precision.
Exactly.
Mental health.
Yeah.
I could talk to you for a long, long more time. I'd like to ask you one final question to wrap up. If you were going to pick 3 pieces of advice to give organizations that wanted to build measurement-based care in their clinics, in their hospitals, whatever, what would you give them?
That's a good question. One is, I think you need a champion, right? You need somebody who is really passionate about the idea of implementing measurement-based care and will help drive and have and be able to bring together a team. So when I say champion, it implies an individual. It can be a team of individuals, but I really do think you need a champion who is willing to do the work, because it is work, right? You have to navigate a lot of these challenges that I alluded to earlier. And so having somebody who will be who will be willing to take on that challenge and champion it is an important. And that person has to identify allies within the system. So champions within champions. So, for example, when we first started the idea of implementing it, I went to a colleague of mine who's now the chair of the department, Dr. Jimmy Potash, and we were thinking about, okay, we want to get measurement-based care up and running, and he helped me think about it. And we went to our large community psychiatry program. It's one outpatient clinic. It's one of our hospitals of our large healthcare system. And we said we wanted to work with them as a starting point. And so we connected with people there who were really starting to come up into this idea of measurement-based care, and we aligned with them. And so there was an alignment of interest.
So that's very important.
Yeah, so it was an alignment of champions to drive it. So I think, I don't know, is that 1 or 2 pieces of advice?
That was 2.
Okay,
yeah,
good.
that was 2. Thank you.
Yeah. So I have to think of a third. I think the third advice is, well, I'm going to give you 2. I'll give you 2 more. So if I can have a bonus one.
You can have a bonus.
One is since you're asking, it's always good to have resources to help those champions.
Very important.
Very important. So if there are any leadership out there listening to this podcast, having those resources is important to be able to support the champions to implement the program, because it requires effort.
Yep. And
effort is time, and time is money. And so that's important. So that was my bonus sort of advice. And then the final one is that this is what we did. And I don't know if it's necessary, but it was necessary for us because the resources were tight. And that is that I think you have to think about building stepwise. I think you have to think about how do we chunk this big problem into one step at a time. That was really measurement-based care was the first step of this idea of a larger learning health system.
Right.
And even that in itself required to break it down into steps. Let's start at this one outpatient community psychiatry clinic, get it up and running in a couple of clinics. And what happened was we were successful, and other clinics saw what we were doing, and that gained momentum. They said, oh, we want to do that. And we got a little bit of momentum going. And so I think breaking it down into steps and thinking about bootstrapping. We've done a lot of bootstrapping along the way, trying to get one step, get success, and build off of that for the next success. So that's my fourth.
Well, thank you so much, very much. I've been speaking with Dr. Peter Zandi, who has given us a lot of insight into building measurement-based care on an institutional level and a national level. So thanks very much.
Thank you for having me. It's been wonderful talking with you.
Thank you so much for listening. Learn more on our website,